Okay, next presentation will be on acetazolamide reduces postoperative pain following laparoscopic inguinal hernia repair, and this will be presented by Dr. Goldblatt.
Okay, good morning. So these are our disclosures. My relationship with industry is related to mesh, but the study that you're seeing that I'm going to present, we believe would not be any different regardless of what type of mesh would be used, and I'll let you make that judgment. All right, so laparoscopic inguinal hernia repair is a minimally invasive procedure. It's associated with lower postoperative pain and faster recovery than an open inguinal hernia repair. Carbonic acid accumulation, which results from carbon dioxide insufflation, has been implicated in postoperative pain following laparoscopy. Acetazolamide is an old drug. It's a diuretic that also it basically inhibits carbonic anhydrase. That's the enzyme that accelerates the carbonic acid formation. So we hypothesized that preoperative administration of acetazolamide would decrease postoperative pain in patients undergoing laparoscopic inguinal herniorrhaphy. So we did a retrospective chart review. We had 66 patients undergoing laparoscopic inguinal hernia repair from October of 2012 until September of 2014. Concomitant procedures other than umbilical hernia were excluded. And in January of 2014, I was approached by one of our anesthesiologists who had initially done a very small case series about 10 years prior, looking at acetazolamide as a rescue drug in the recovery room for shoulder pain following laparoscopy, typically lap chole and gynecologic procedures. So he recommended that maybe we just try giving some acetazolamide to the patients preoperatively, and so from January 2014 on, I started doing that. No other changes were done in my technique from that time period, so basically this is the only change that happened with the patient. So we measured morphine equivalents that were calculated to compare postoperative pain treatments, and then using the visual analog scale, we measured pre- and postoperative pain. So we ended up with 44 subjects in our control group and 22 subjects in our acetazolamide group. There were really no significant differences in the population. BMI was relatively lean for your average Wisconsin population, but the bilateral nature was similar. Interestingly, the number of concomitant umbilical hernias was greater in the acetazolamide group. And these are our results. So the visual analog pain scores before surgery, there was no difference between the control groups and the acetazolamide group. The control is in blue and the acetazolamide is in green. The first responsive pain response, which is essentially when the patients hit the recovery room, the nurses ask them, how much pain are you feeling? You can see the difference there, significantly different. The difference seems to go away right prior to discharge, but interestingly, our hospital has a policy to follow up and call the patients on post-op day one, make sure everything's going okay, and then in that phone call they ask them how much pain are they having, and the difference that we noticed immediately after surgery continued even after the drug, whose half-life is about 4 to 6 hours, had worn off. So this is a graph showing the visual analog scale for the first 8 hours after acetazolamide administration. Now, I didn't put error bars on here, and I apologize for that, but the drug typically wears off after about 8 hours, and you can see that they're in the first few hours after surgery, and so this is once the patients were given the medication preoperatively, the surgery takes place, and so the first real estimate as far as which pain score we're looking at is typically about 3 or 4 hours after the drug had been given. And there's a difference in the acetazolamide group versus the controls, but that difference seems to go away. And I think there's a bias in this, or a misleading notion in this graph, because as you get about 10 hours out, there's very few subjects that far out. Most patients have already gone home by that point. And for whatever reason, the patients that haven't gone home are having some issues, typically urinary retention issues. And so I think this may be a little bit misleading as we go further out. When we add up the total amount of analgesics administered, whether it's morphine or Dilaudid in the recovery room, or the number of Percocets that they're given in the outpatient surgery area, there's a significant difference between the acetazolamide group and the control group. So in conclusion, acetazolamide administration showed a reduction of pain in the immediate postoperative setting. Patients who received acetazolamide required fewer opioids to manage their pain over the course of their recovery prior to discharge, suggesting a reduction in pain. And acetazolamide is an inexpensive and safe adjunct to treat postoperative pain in laparoscopic inguinal hernia. Thank you.
I'm at John Lynn, Chicago, great study. Just two questions. Number one, what was the dose you gave? And the second was, you alluded a little bit to urinary retention, and there's some thought that if these people get a lot of IV fluid or their bladder fills up, their risk of urinary retention is going to be higher. Did you see any change in the number of patients who got urinary retention post-op as a result of getting diuresis and having their bladder fill up immediately post-op?
So first question, the dose is 250 milligrams, which is actually a little bit on the light side as far as the dose is concerned. Some of the larger patients could probably have 500 milligrams, but we just kept it to 250 milligrams. The urinary retention, interestingly, and I didn't present it here, thankfully our urinary retention rate is relatively low, so, less than about 5%, but there were, in this total study, there were about 2 patients that had urinary retention, and they were both in the control group. So, but it's clearly underpowered to determine if there's a difference in urinary retention.
Yeah, thanks for that great study. I have a question. So it looked like from your results, there's definite value in doing this in terms of the patient satisfaction and pain. I'm wondering about the cost of this, and if Bruce Ramshaw has been working on reducing pain with lap ventral, and one of the things he's done is a reduced pneumoperitoneum. There's limitations to that, I imagine, for this inguinal approach in terms of visualization. But I'm wondering if you have expanded this to other laparoscopic procedures.
So based on the results of this, so the cost, acetazolamide is an old drug that it's generic, and I believe the cost is a few cents a pill. I mean, it's negligible, the amount that it adds to the patient. I mean, I'm sure our hospital charges them $50, but it's almost free. So I've just basically, any laparoscopic case now, I just give the patients acetazolamide. There are a couple of reasons not to. If they have a sulfa allergy, there's a sulfa connection with acetazolamide, so you're not supposed to give it if they have a sulfa allergy. And anyone with any type of renal impairment, we haven't been giving it either, just because it is a diuretic. But for an average healthy patient, we've been giving it for everybody. I mean, anecdotally, it seems to be working, but I haven't looked at the data like I have with the lap inguinal group.
So can I ask you, so, I mean, it's kind of hard to believe, to be honest. So, like, I guess my first question is, do you really believe that this is really happening, or do you think this is just a small group and kind of needs to be done bigger, is my first question. And then to kind of validate that, so is everybody in your practice now standing at the pre-op bed saying, make sure this patient gets acetazolamide? Has it completely changed the way you guys do lap inguinal hernias now?
So the anesthesiologist who came up with this idea over 10 years ago thought about this while he was doing some high altitude hiking. And if you've ever done, acetazolamide is Diamox, and you take it if you go mountain climbing, because it shifts, it makes you I believe it makes you a little bit more acidotic, which forces you to breathe more, so you have less effects of the hypoxia. But anyone who's done that and then gone off the mountain and opened up a can of Coke knows that can of Coke tastes awful, because the normal fizz and burn that you get from a carbonated beverage that we all are used to is completely gone. And that's when he came up with the idea that you got to know the guy to understand why he would do this in the middle of a hiking trip. But anyway, he's like, I wonder if this would help with laparoscopic pain. And so it takes a very small dose of this to realize that burn that you get from carbon dioxide is completely gone. And so, you've got this large surface area in the, preperitoneal space that the carbon dioxide elicits a little bit of a burn, and with the theoretically with the carbonic anhydrase inhibitor, then you don't get the burn. So yeah, I mean, it does seem to make sense. But
So is Gould doing it, or all those guys? Are they on board?
I think it's just me who's doing it.
Spencer Amory from New York. I like your presentation. I like simple ideas that help patients. Along the same lines, obviously the care team was not blinded to this intervention. Were the patients blinded that they were receiving a drug that might decrease their postoperative pain?
No, this was not blinded, right? So and to make this a much more appreciated study, obviously, we would do, taking this initial data, we would do a double-blinded prospective trial to see if it would make a difference. There were no placebos given, and the patients definitely knew that they were getting something that was supposed to help with their pain. Yeah.
Okay, thank you very much.
Yep.